So thank you for inviting me. I had done a video presentation that was exactly 10 minutes and 4 seconds, so I was going to prepare that, but because I could come today, I looked at my video presentation on the train. It looked a bit dry, so I thought I'd actually be here and talk. So if it's a bit over 10 minutes, I apologize. I'll try. And then in the train, I sort of did that, and now I've just completely ripped it up and just done a few lines because there seemed to be some things that I needed to talk about in response. I could stand here and just talk to Google because I need Google, but I'll talk to everybody. So I've been an NHS doctor for 30 years. Sorry, I need to be closer. No, it's quite low enough for me. Yeah. I trained in hospital medicine initially, changed to general practice for the last 21 of those, but actually I gave up 2 years ago to try and help unlock people's communication with motor neuron disease, ALS, locked-in syndrome, and cerebral palsy. The reason I did that, well, so I started a company called EarSwitch, and what we're trying to do, or we're doing, is earbuds that you can control hands-free, invisibly, silently. And initially to unlock people with motor neuron disease and other conditions like that, but also to give everyone hands-free control. And as we know with texting, if you address accessibility issues with the most people the most need, you address it for everybody. So texting started for people who couldn't use phones because of hearing issues, but now we use texting all the time, using WhatsApp or whatever. So the reason I started this journey was because as a medical student 30 years ago, I witnessed someone with bulbar ALS or MND who lost their speech before they'd lost the use of their fingers. And at that time, the best technology was a keyboard with an LED display that they could type on. It came up with a sort of ticker tape display. But obviously, in that situation, although it was the best technology at the time, people would then rapidly lose the ability to use their fingers. And I saw this person losing the ability to use the one communication aid they had. And I thought there had to be a better way. And at that point, I knew I could squeeze a muscle in my ear. I didn't know what it was. And I thought, I wonder if you could use that to communicate. For 25 years, that idea festered. And I came back to it intermittently, and I just couldn't work it out. And then 5 years ago, my daughters were watching a children's documentary about an amazing 13-year-old called Jonathan Bryan. And if you haven't come across him, please look him up. He wrote a book, age 13, called I Can Write, EYE, Can Write. His mother had had a severe car accident when she was pregnant with him, and he was born prematurely with severe cerebral palsy, non-verbal, athetoid cerebral palsy, so he had severe involuntary head movements, a bad squint, which meant that he couldn't use eye tracking. So he'd been labelled as having profound and multiple learning disabilities. But his mum took him out of school age 7 because although they were caring for him, they weren't teaching him. And she knew he was in there, so she taught him to read and write with a physical spelling board, with a perspex spelling board with letters attached to it. And they looked at where he was looking to see what letters he was selecting. By age 13, he'd written a book. The first third is written by Chantal, his mother, who's fantastic, very devoted. The second 2/3 are Jonathan's story about being locked in. And can I recommend that book to you? He also started a charity called Teach Us Too, which says that no one should be labelled as profound and multiple learning disabilities. They should be labelled as profound and multiple access to learning difficulties, because until you've actually taught them, you don't know. So they've been supporting us, which is fantastic. So what I found, the day after seeing that documentary, I had from Amazon delivered a digital otoscope, so a stethoscope that's been designed to look in your ears to look for wax. I looked in my ear and I saw my eardrum moved intentionally with squeezing this muscle in my ear. And I thought, well, there it is. You can control things. So this is replacing the cheek switch that Professor Stephen Hawking used. So he retained a little cheek muscle movement, and he used that as a on-off switch to control the keyboard that Intel designed for him, could be controlled with a one switch movement. So we've got that, but in your ear. People say, how do you do it? So for those of you, 55% of you should know that you can squeeze a muscle in your ear. We did a survey of 2,000 people, and 55% of people knew this already. And they've been doing it since childhood, and it's just a squeezing sensation in your ear. If you're looking at me blankly, then you can recognize it when you yawn. If when you yawn, you notice you don't hear as well, you get a fullness sensation in your ear, you get a rumbling, or it's also been described as a pelvic floor exercise in your ear. That is the muscle pulling in. Now, once you know it's there, we know that people can be trained to use it. and trained to use it intermittently. So I'm squeezing at the moment, and you wouldn't know I'm doing it. So we can use that as a hands-free control. At the moment, we've been very well supported with 3 National Institute for Health Research grants, and we're just about to produce our second prototype and put it to clinical trials. So we hope to have these available by middle of next year for people to unlock their communication. We can't use it for assistive environmental controls yet because obviously the safety issues about driving electric chairs and things like that are a lot higher than communication issues. But we hope to move on to be an augmentative control for everybody, for anything. But more than that, we hope it to be, one of the titles we put, the future with assistive technology built in. Obviously everyone wants hands-free control. So we're hoping that the big tech companies, I'm not looking over to my left here, will put ear control in their earbuds so that everyone uses their ear control for skipping a track, answering the phone, starting their GoPro. But people can then buy a mass-produced, low-cost, high-spec device, your standard smart earphones with our technology in it. And our technology is down to 1 millimeter square sensor, which is an off-the-shelf sensor. So basically, there's room for it. And what we're hoping for is, therefore, the same smart earphones that people without disabilities buy can be bought by everybody, and they get that accessibility. But more than that, your eardrums move with eye movements. So when you look to your left eardrum moves in. When you look to your right eardrum moves in. And when you look up and down, you get a different ear movement. So we can track your gaze from your ears. And we hope to get eye tracking, not just gaze tracking, but we don't know that yet. So we're in the middle of looking at how we do that. So that's our story. I think one of the things I wanted to do was, a couple of things. To start with one, I thought was really important, and we've struggled. So one of the call outs I've got to everybody is to actually how we accelerate technology to market and to those individuals. And I had massive blocks, even with some organizations within the UK who were specifically commissioned to help people with disabilities, saying, well, tell us how many people can move this muscle. I was saying, well, I don't care. If I unlock one person, I've done the right thing. It works for me. Let's see if we can get it. And obviously you have to go down the medical device route, which is class 1 medical device, because you're replacing a function lost through disabilities. But even so, I've struggled, and the one organization that's helped is National Institute for Health Research and the funding. But again, it's taken 5 years to get to this stage, and we still haven't actually unlocked anyone at all yet. We have a fantastic expert group. We have our own Antoinette. We have Sarah Ezekiel, who some of you might know, who's non-verbal with motor neuron disease, and she's an eye tracking artist. So look up Sarah Ezekiel. She's got amazing work. And we've got someone with C4 spinal injury. We've got Jonathan Bryan is supporting us. So we're hopefully doing the right thing. We're always asking, are we doing the right thing? So my call out is really to look at systems that allow us to get technology to everybody, because as we all know, we're all individuals, but people with disability, I feel a bit of imposter saying this because I've never been discriminated against. I did grow up as a child in a family with disability, but I've never been discriminated against myself, and I've seen a lot of patients who've been discriminated against. So everyone needs a personalized solution, and there are lots of people out there who can help. So we're working now with, I think, 8 or 9 universities, and there are some amazing technologists, particularly mechatronics, robotics, electronics engineering, who would love to have the opportunity to help just one person. There's people down at the University of West of England where they're doing single eye tracking, which would be fantastic for Jonathan, but there's no link that allows them to get technology out to people as an individual. The closest thing we've got is exceptional use that the MHRA can, in the UK, sorry, I know this is an international audience and global audience, but in the UK, the MHRA can grant exceptional use based on improved mortality or morbidity. Now, I challenge anyone that if someone's got MND or ALS in late stage and they can't communicate, I say they have an urgent need, both for their morbidity, in other words, their psychological morbidity to be able to communicate, and their mortality to communicate their symptoms. So I think there's a real good use case for anyone with late-stage MND or ALS. But we've not found a way to do that yet. Hopefully we won't need that soon because we'll have a medical approved device by the middle of next year. But it's a bit disappointing. So that's one thing. And the second thing is looking at some system where we can bring together academics, clinicians, users, stakeholders and MHRA and medical physicists from local hospitals to come together a committee to actually take on individual use cases. So that's my challenge to everybody. Hopefully you'll see more of EarSwitch, because EarSwitch is also moving into earmetrics, so providing racially inclusive oximetry from your ears, because that's been a massive problem during COVID. And what we've found is that our sensors not just give people control, they give continuous real-time monitoring, which will extend from heart rate variability, oxygen levels, etc. So we're hoping to change a lot in the world. So thank you.
Wow, thank you so much.
Nice to see you.
Thank you so much for coming and sharing that story, which I didn't know. And the small point in parenthesis at the end about racially inclusive oximetry is not a small point at all. I think